So welcome to the Dental Codology Insiders Mastermind for August. Really excited about our subject tonight, and I know we have people on the phone and we have people coming in, and Kandra is here with us, which is awesome. Again, our masterminds are our think tanks. This is not a lecture, it is a mastermind, which means we talk to each other. Again, it's for PACE AGD continuing education credit. In order to get credit, we need two things, and that is a course description, as well as you to sign in. Now, I know we have a bunch of people on the phone, and Lindsay Hill is here to help get everybody's name when we go over the list. But the easiest way is to put your full name. I need first and last, because this is what I need for our, in order to provide continuing education credits. While a few more people sign in, I will also mention that Lindsay is the amazing person who has worked really hard for all of our masterminds. We now have CE questions for every mastermind going back to February of 2018. That means if you missed a mastermind along the way, you can go online, listen to the mastermind, and then there's some questions that you take, and that's how you get your CE credit. So that's an awesome opportunity that you have if you missed them along the way or you want to go back and watch them again. So Lindsay, are you ready?
I'm with you.
All right, terrific. Here we go. So Alex, I know Alex is here because Alex was the first one here. So Alex, you can say hi. Alex?
Hello. Hello.
Hello. There he is. Thank you. Next is Angela. Are you here, Angela? Nope. Barbie's here. Say hi, Barbie, again.
Hi, everyone.
There we go. Chris Maiello, are you here? Not yet. Krista McConaughey? I saw our beautiful Connie just come in. Say hi, Connie.
I'm here, everyone.
There she is. Hello, Denise.
Hi, everyone.
There she is. Diana Corbin, are you here yet? Nope. Eileen. Say hi, Eileen.
Hello, everybody.
There we are. I want to hear your voice. I know how feisty you are. I love you.
Love you back.
Ellen Anderson.
Hello.
Hi, Ellen.
Hello.
Nice
I'm
to have
here.
you. Jan Palmer, are you here? No? How about you, Jean Wentz?
I'm here.
There
Hello.
she is. How about Jennifer Z? She here yet? Nope. Jill? Jill Rasmus? Jill Rogie? Nope. Joanna Massa? Not yet. Kandra Sellars, are you here?
I am.
Thank you. I'm so glad.
I am.
Kate McGonigal, say hi.
Hi, everyone.
She's one of Kate joined us on our mastermind last month, and she has since joined our Insiders Network. We're really thrilled to have you here. Kathy Forbes, Kathy, are you here? Talked to Kathy earlier today. Okay. Kim, you're here, right? Kim Jockheim?
Yep, I'm here.
There she is. Kimberly McElwee? Not yet. Kirsten Jarvie from California? Not yet. How about Chris Koss? Not yet. Lanny, I just saw you come in. Lanny Macbeth?
I'm here.
There she is, another one of our new awesome members. New member. All right. We also have, let's go to the next one. Lee? No. Linda Jorgensen. You're here, aren't you, Lynn?
I most certainly am here. Hi.
There she is. That's a beautiful voice. Lindsay Hill, of course, you're here. Mark yourself, Lindsay. Lisa. I think Lisa Simonson, right?
I'm here.
There she is.
Hello.
Liz Broma? Liz, are you here yet? Nope. How about our other Liz, Liz Neese? Not yet? How about Lucy up in Wisconsin? Not yet? Michelle? Our poor Michelle Race is still sick. She ended up having to go to the doctor today. She's been sick ever since ADHA. We sure hope she gets better soon. Nancy Brohan.
Hello.
There she is. Paige, are you here yet, Paige? Nope. Katie B, you're here, right?
I am, and I'm actually on. I
Oh,
can
you
see
can
a
see it from
screen.
your phone. Cool.
Yeah.
Cool. How about Rhoda? Are you here, Rhoda? No. How about Sandy? You're here, right? Sandy Rival?
Yes, I am. Yep, I am here.
Terrific. And I just saw Sandra Berger come in. Say hi, Sandra.
Hello. Yep.
There
I'm glad
she
you.
is.
I'm glad you go by first names and not last names.
How about Sharon Smith? Are you here? No. Val?
Hey, good evening, everyone.
Oh, we're so thrilled to have you. Remember,
So,
you come to Chicago, you better call me. And
I am. I'm coming in September. You're on. I'm going to give you a ring next week.
there we go. And Vicki Feeder is here, right, Vicki?
Yes, I am. Hello.
There she is. And Jennifer Bruckner, are you here? Did I see you come in? Jennifer? Yes. Say hi, Jennifer. Jennifer is our newest member of our insiders group. Say hi. And Jennifer, anybody that's into it, is there anybody here that I have not already, that I haven't recognized? Because again, Lindsay wants to mark you down as present. Anybody? Okay. Again, we have two people that we got waiting for names they're in, but they haven't put a name in. So please put your name in, and we need to make sure, and Lindsay, you need to check also if you can check the attendees over there and kind of watch for it. I'll announce it again, because in order to get your CE, oh, there's Chris Mallow, we need to have your name recorded. So as part of your insider membership, you're all part of the Dental Codology Consortium. Our next consortium meeting is on Sunday, the 25th of August. But I got to tell you, our work groups are doing some amazing things. Our work groups include the implant maintenance, biofilm management, and that's led by Melissa Obraka with Jill Grasmick as the mentor. And as some of you may have heard, that I was just talking to Barbie about, is one of the things about all of these work group meetings, they are on the insider portal, so you can go in and look at them if you choose to. Patty Korecki is the chair of our provider language group. She's mentored by Kathy Bates. Patty was going to be here tonight, but she is sick with the flu. So anyway, I'll give our best to healing for Patty Korecki. Our more Profi Code, no wait, Patty Korecki's group is mentored by Patty Beeson, because we have two Patties together. Anyway, our more Profi Codes group is Tasha Bates with Kathy with Kathy as her mentor. Oral cancer evaluation is Susan Cotton with me, and that group is going like gangbusters, and we're thrilled with that. We also have our non-therapeutic products, our drugs. Jamie Collins, who isn't able to be here tonight, and she's working with Linda. Linda, you're working with Jamie, right? Linda Jorgensen?
Yes, ma'am.
Yeah, there we go. There we go. Anyway, let's see, this guy's holding up an x-ray. Well, guess what he sees in this x-ray? This is just so funny, I needed to share it with you. At Under One Roof last week, or week and a half ago, we had a table, and our badges were not available when we got there. So we ended up going over and having somebody had to create them at the time. And as you can see, even though I spelled it, Patty Beeson spelled it right, rather than it being dental codology, it was dental code allergy. And we think that that is so funny and so accurate. We're going to play on it because we believe in this group, we have some allergy relief for people with dental code allergy, and we need your help. Within the next week or so, maybe a little longer depending on my vacation, we're going to set out a survey. And what we're going to ask is for you to help us define what a dental code allergy is. What does that mean? Yes, it's cute. Yes, it's funny. But I think it's kind of real. I really do. I think sometimes when people hear about codes, they almost want to go into anaphylactic shock, and they need some Benadryl. So anyway, we'll be talking to each of you and sending you some information because your thoughts are going to help us formulate this plan that we're moving forward, because we're always looking to build our group, to build the Insiders Network, and you can help us do that. Next week, actually the 25th is the next one, the next Smart Bulletin will be available. If you have something, if you have a question yourself, or you see something particularly goofy on, say, Facebook especially, or any of the other social media, please send those questions to me, or those comments, or just do a screenshot of what's going on Facebook, because that's how this column of the antidotes for Facebook has been created. You will see more about dental code allergy there as that program develops. Next month, we have our wonderful Sandra Berger, and she's all going to give us weed. Oh, no, is that part of the course description, Sandra? She's going to talk to us about marijuana and cannabis and CBD oil, and she's become quite the expert on this subject. And I'm really excited to learn, because I know that even with my husband and his own health situation, his chronic pain doctor said the best thing for him and what he is the best to use at this point is CBD oil. And I know we have a lot more to learn. Sandra, did you want to add anything to that?
No, it's something I'm constantly learning about, and I could talk about it for a week and still not cover it all. I learned a lot in Texas about gun use and marijuana, and legal marijuana, and it's just very interesting to me.
Well, it's exciting. I know it's very interesting to me. Again, it's hitting home personally in our lives. So yes. Anyway, so that's next month. That is on Wednesday. We try to rotate these masterminds Monday, Tuesday, and Wednesday, and anywhere from 6 o'clock to or 7 o'clock. I know for our West Eastern people, it's already 8 o'clock, and it's hard for our Western people, and especially our Hawaii and Alaska, because it is so early for you. So we do try to rotate those. So next time it will be on Wednesday. It will still be at 7 o'clock because Sandra's in the Eastern time zone, so it's already 8 o'clock for her. So anyway, you'll get your e-bite as usual on that in advance. Again, to qualify for the mastermind, to get your continuing education credit, as you can see, there's the CE already done. I need your first and last name in the chat box. If you haven't yet done that, please put that in. So remember, this is a mastermind. This is a safe place to talk. The content that Kandra has put together for us, I know she wants us to ask questions. This is an area that's so important when we talk about the possibilities of billing to medical, and she is truly the expert about that. So let me give you a little bit more background on Kandra. I actually met Kandra a few years ago when she moved from Minnesota, and Kandra has quite a background. She created the Pristine Interprofessional Academy, and her focus is on interprofessional collaboration between dental and medical professionals. And that's so we can elevate the patient's care and save lives. With her academy, Kandra is able to educate, implement processes, and professionally coach doctors and teams to the next level where the dental profession is heading. And actually, it's not just that it's heading there. Kandra is really one of the leaders in helping us get there. She's quite a wealth of knowledge, and as she is the same way that Sandra just described for herself, every day, every moment is a learning experience. So rather than me talk more about Kandra, how about if we let Kandra talk? So here we go, Kandra. The platform is yours.
All right. Thank you, Patty. First off, I want to thank everybody for being on this call, because I know how important it is, your evening times. It seems like there's a lot of webinars available, and, it's hard to fit it all in sometimes. But what I do know is that this group of people is, you guys are so much farther along than a lot of other dental hygienists and dental professionals out there. I really appreciate your time, and I welcome any questions as we go through this, because there's a lot of information and it's kind of overwhelming at first. So I'm sure you'll have a lot of questions for me, which is good. Patty, there you go. So this is something, the medically necessary coding, that's something that Patty and I came up with, because we always hear about what's medically necessary. We know that there is a huge link between the mouth and the overall health. And there's an abundance of research. I mean, there's really no question any longer that there is a true connection between the mouth and the systemic system. And it's surprising to me, Patty, if you want to switch to the next one. It's surprising to me the great divide that we have between medical and dental, even with all of this research. I mean, I remember a time when, we talked about, I think it was, I want to say it was probably, do we need to pre-medicate for, mitral valve and heart murmurs and things like this? And then there was this talk about, is there really a link with the heart? And I remember that. I was working with the periodontist. And it was a big topic, and then it kind of went away, and it was poo-pooed. And this, this isn't true. This is just, like you can, like all the things that we can eat one day and not the other day, the next day. It seems like, it's a constantly changing world out there. But there is no doubt that there is a connection, and I learned that early on in my career, seeing patients in a perio office, and seeing the true connection and identifying when something wasn't right, because I was doing everything that I could as a hygienist and they weren't getting healthier. So there's definitely a link, and we know that. So my goal is to try to help collaborate this and get things moving more towards medical than dental. Patty, can go to the next one. So I think one of the mind shifts that we all need to look at is we truly are a medical specialty. We're no different than an ENT, an anesthesiologist, optometrist, whatever specialty you want to have, whatever you want to think of. We are truly a medical specialist. And even on some of the EOBs that we are getting now, it actually says specialist written on it, and the copays are applied as such. So I love seeing that. It's great to see people starting to recognize us as true specialists. We do not just count teeth. There's so much more than we do. When we do a head and neck evaluation, we're not looking at the teeth at all. We're doing a complete, dive in as far as what's going on the head and neck. Are we feeling any lumps, bumps, lesions, anything abnormal? Is the jaw joint okay? That has nothing to do with dentistry. Dentistry is truly a practice of fixing teeth. Can you go to the next one, Patty? And I get this question all the time. Are you sure we can bill to medical? And we absolutely can. And the one thing that I just had this conversation with the doctor yesterday. She's like, I'm just afraid we're going to get going on this process and we're not going to get any reimbursement. If we can go into any other specialist and bill out, and they will bill out an exam for us. I mean, I'm just going to take it back to something really simple, an exam. If the insurance company will pay another provider type for that same level of service, an exam, an evaluation, they cannot discriminate against our profession and not pay us for that. The same thing is true for Panorex and CT and a lot of other things that we do in dentistry. So we definitely should be looking at dental as more of a supplemental insurance, because unless you're general practice, there's very few things that we truly do that's truly dental related. Patty? So where the division really comes is, this is crazy to me. The longer that I'm in medical billing, is that in medical billing we have to have a diagnosis code in order to get paid. I recently just got a bunch of claims from a practice because the doctor was questioning whether or not this was real, and all the claims didn't have any diagnosis codes. And I'm like, how many of these did you get paid on? None. And it's like we have to diagnose before we can actually get paid on anything. And I'm always really shocked by how in dentistry we just do. We see the patient. We have a game plan. There's no doubt that we have established necessity and need, but have we actually made a true diagnosis? Is there anybody here that's actually using the blanks on the dental form where diagnosis codes go? And not only that, do you know what a diagnosis code is? Does anybody know?
It's box 34A on the form.
And I was reading something from Medicare. They're going to be changing how they pay for their exam and the levels of their exams in 2021. And one thing that is going to be a game changer, and I love seeing this, is that say a patient comes in and they're billed out. I know some of the terms you may not know, but say it's a level 3 exam and we have a patient that's very healthy. They don't have any complications in their medical history or anything like that. And Medicare is going to pay, and file other insurance companies, because most follow the Medicare guidelines, and Medicare leads pretty much everything. So that patient's, the provider is going to get paid a certain amount for that patient. Say another patient comes in and they actually have comorbidities. Say they're diabetic or they have hypertension or whatever it might be, and the provider codes it a level 3. If they have that diagnosis of a comorbidity in on their claim form, that provider is going to get paid more for that same level of exam with the comorbidity listed. So I love that, because they're recognizing that we need to elevate the standard of care. And we need to understand that whatever treatment we do for somebody that's very healthy versus somebody that's not, or I shouldn't say that a diabetic or somebody with hypertension is not healthy, because that's not always the case, but that there's a different level of outcome with all of those patients than there is with somebody that has no complications. And it takes more time to think and process through the information that they are given, that's presented in front of them. So dentists and MDs, they get paid to think. And that's, when you walk into a medical practice, do you see much equipment there? There is none for the most part. They get paid to think all day long and refer for CTs or CAT scans or whatever, the blood work, lab work, whatever the next things are. But the procedures, they typically aren't doing that actually in their practice on that day that you come in for a visit. So it's very different philosophy than in dental. So I came up with this, what is medical necessity? Because I think people have a hard time wrapping their head around what is medically necessary. It has to be appropriate, it has to be reasonable, and it has to be adequate for the condition. So, say there's a patient, I'm just going to use something way off the radar here, but say there's a patient that has, that can't physically move around very well, and they need a chairlift to go up and down their stairs in their home, because the outcome would be if they fall down those stairs, there's going to be a heck of a lot more medical claims going on for that patient, and potentially a life lost if something would happen to them and they fell. So would they now pay for the chairlift? Yes, they may. So it has to make sense. It has to make complete sense in the situation of what we're trying to ask to be paid for. Is it truly medically necessary? And when it comes to dental, we're looking a lot at function. Are they able to function?
Can I say something here, Kandra? Think about, what if we even started using that terminology, medically necessary, when we're talking about periodontal treatment, periodontal therapy? Because how many people, they don't want to have it, But if we put it into the realm of a medically necessary treatment, it changes the game, doesn't it?
And that's one reason I brought up the teaser about, diabetics. Well, is there a seriously different outcome with a diabetic with periodontal disease than somebody that's not? And I'm starting to see even some of the dental insurances say, hey, we'll pay, I think it's Cigna. I saw this sheet where they actually will allow, as long as you fill this sheet out and you give them some background about the patient, they will pay for extra cleanings a year, even if it's not stated in their policy, because they realize that it's going to cost them more money to actually take care of that patient if their periodontal disease is not healthy and they have diabetes. So there's definitely starting to be some collaboration of this. I'd still like to see that paid on the medical side. And there is ways to get periodontal therapy paid for in medical. It's just a heck of a lot harder still than some of the other procedures that we do in the dental practice that are pretty much slam dunks that I'll talk about in a little bit. I can't wait for the day that we see all of the stuff that we do in hygiene, a lot of it get covered in medical, because it really should. Absolutely.
I can't wait for the day that there aren't dental codes at all. Because dental codes are stupid.
And that's a lot coming from the expert of dental codes.
Yeah. Medical necessity came to my office today. We had prescribed Prevident fluoride, and we got from Horizon Blue Cross a whole fax of medical necessity, diagnosis codes, and all that for them to cover a prescription for Prevident.
They requested that?
Yeah, and wanted medical necessity.
Cool.
Asked
Who was
for
that?
medical necessity.
Who's talking?
I'm sorry, Eileen Prizzi.
Hi, Eileen. Wow.
Hi.
Can you send that to us so everybody else can see it, or do you have a copy of it?
I will get a copy of it, but they sent a fax. You need medical necessity. Has this patient had this before? What's the reason why you're prescribing it? Are there any known interactions for Prevident? And this is Blue Cross.
That Blue Cross of what state?
Horizon. I'm in New Jersey.
Okay. Yeah, and there's actually codes on a drug code that we can use on a medical claim to submit that to medical.
Yeah. What I entered, I think it was K09, was unspecified dental caries. Because they wanted the ICD-10.
Sure. Yep. And a lot of the K codes, all the K codes have to do with the mouth. And I try to stay away from K codes if I can find another code, because it puts us back in that wheelhouse. And for some reason in medical, as soon as they hear dentist, they have no idea really what we're all about and the gap that's there. Especially most of the people that are just, calling, that you talk to on the phone, they really have no idea that the head is even connected to the rest of the body. It just blows my mind sometimes.
This might be premature yet. Aren't the K codes the ones that are the best that go on the dental forms, though?
Yes, for dental, yeah, because we're submitting to dental and that's focused on the mouth. But when we go into medical, I try to list those last because, again, it just highlights dental.
Right.
Unfortunately.
But what I can do is when each of you get your CE certificates after this course, I will send you the list of the K codes mapped onto, so it's a beginning thought process. What Kandra is talking about is so very important, because this isn't, as Eileen just said it, this isn't where we're going, it's where we are. And we need to start thinking this through every part of the visit, through the documentation, through all aspects of the treatment that we get, that we are medical specialists. And we need to think through that, through always through the lens of medical necessity. So, all right, I'll move on. There we go.
All right. So again, we tend to think of, people will say, well, I don't know what a dental diagnosis code is, and there is no such thing as a dental diagnostic code. It's all a medical code, and it can be used obviously in dental as well. But I mean, if there was dental diagnosis codes, we would have learned them in school. So there is no such thing. What it comes down to is medical diagnosis will give you medically necessary treatment, which will cause reimbursement from payment. So that's the difference. And I would challenge you guys to start thinking in that line of thinking of, you know, what is really going on here. I actually had a client who was struggling with diagnosis codes, and he wanted me to prior authorize a TMJ appliance. And I gave him the codes. I gave him my super bill, and I said, okay, figure out, tell me what this is, because the only one that can truly give diagnosis codes to a biller is the doctor. And he filled it out. And I was like, you know, doc, it seems like this patient might actually have a sleep apnea issue, because every code that you hit on is actually a diagnostic code for sleep apnea. Now, if you put a TMJ appliance into somebody that's apneic, you're creating a really bad problem. And, you know, it was like, so his initial thought process of what he wanted to do to treat this patient was completely different once he actually sat down and looked at the diagnosis codes. So that's the difference. I think we do things all day long without truly diagnosing what the problem is and really thinking about it more broad. It's not just about the mouth. Patty, go ahead. So look at this picture. This is Jack. Now, first off, who here first saw the teeth? Because that's usually what you're going to go to. But I want you to start looking beyond the teeth, and what else do you see? Somebody call out what you see.
Advanced bone loss.
Mm-hmm. What else?
Missing teeth.
Cloudy sinuses.
Huh? Keep going. What else? Don't even try to ignore the teeth. And I know we all want to get in there that are hygienists, and we want to clean those bad boys because they're really gnarly. These are some of the ones we'd have to hold in while you're trying to clean them, right?
Yeah.
Go ahead, Patty, and just pop up the diagnosis codes for Jack. So this is what Jack really has, and this is what medical is going to look at. We've got disuse atrophy. We have pneumatization of the maxillary sinus, which it means that the bone is really thin. Now, from a medical standpoint, that's a concern, because how easy would it be to perforate the sinus? It'd be really easy to perforate it. It also would be very easy to fracture the jaw. Now, that's a whole nother problem that, I mean, think about that for the patient. Obviously, we do have aggressive peria. We've got embedded teeth. This person had a personal history of nicotine dependence, and we did a screening for oral maxillofacial cancer. So I mean, you know, look at and the order does matter too. So look at the top two codes. Do they have anything to do with the teeth? Nope. So would we be looking at for this particular patient? Would we be looking at more medical or dental? I don't know how many teeth Jack is going to have retained after, you know, full evaluation. It's not looking too promising. But when I first see this, I'm looking at, oh my gosh, you know, we could potentially not, I don't know, you can't see the other side very well, but we're getting close to that mandibular nerve. So that's a problem too. We have a lot of other problems other than the teeth in this patient. Not to mention all the systemic infection that's going on because of what's here. The cysts and all the other things that are going on.
And all the systemic infection that may be contributing if we don't have a history.
Right. Right. So I mean, typically when I see a pan, I'm not even looking at the teeth anymore, and I never thought as a hygienist I'd be at that point. But there's so much more going on with this patient than the teeth. We've got a lot of things that we need to fix that are bigger than a tooth problem. Patty, go ahead and go to the next slide. So here's a list of the things that we can start billing to. So exams, consultations, radiographs, and CTs. Those are all no-brainers. Trauma trumps everything. Most plans have trauma is absolutely payable. I have seen a few where they've even excluded any kind of trauma. I mean, it's just crazy, some of the policies that I see, and those are typically the ones that are not as quality. But some of these exclusions that these insurance companies are putting on the mouth. I had a patient he had oral cancer actually, and he couldn't eat. He had several. He had periodontal disease like crazy. He had several cysts in his mouth, or abscesses, what we call abscesses in dental. And the insurance company, the medical insurance company, wanted to put him through hyperbaric chamber therapy first for extractions instead of trying to save his teeth. The guy couldn't eat. And he was just a walking time bomb with all the cysts that were in his mouth. It was crazy. But his insurance actually had a rider on all, or not a rider, but an exclusion on all of that. Surgical and surgical prosthetic. So implants, bone grafting, cyst removal. Those are probably the biggest ones that I bill for. And along with that, we have interim prosthesis that go along with those surgeries. We also have final prosthesis and surgical stents. So all of those things will be billable because they'll pay for the actual grafting or bone stabilizers. So, and then we've got durable
implants fit in there.
What's that?
Implant surgery?
Oh, they're called bone stabilizers in medical.
Oh, there we go. That's part of what I wanted you to say.
Yeah. Thank you, Patty, because I get so used to the terminology in medicine, I'm forgetting what the slang we put into it in dental practices. So I apologize.
What you're saying right here is including the placement of bone stabilizers into the surgical site. That means implants in our world.
Yes.
Yes. Okay.
And a lot of people say, well, we do sinus lifts. Well, it's just a graft. It's the same thing. It's just a graft. We have a lot of fancy terminology, or slang that we sometimes add to our dental verbiage, but it's just a graft. CBCT, it's a CT. You don't hear when you go to the medical doctor, we're going to do a CBCT. They're going to do a CT. So
I read an article. I actually proofed an article on update on what's going on with radiographic images. And what that article said was that when CT came to dentistry, it was a specific decision to call it CBCT to almost make it sound like it's not the same as a medical CT. Because all of us know that there's a significant exposure to radiation with a CT. And the CBCT language was to make that sound like there's less, even if there isn't.
And let's talk about that, Patty, because isn't that when we try to sugarcoat things for our patients, and it's like, I think it's devalued us. I think it's devalued our service. I don't know. What is anybody else's thought on that? I just feel like, why do we do that? This is important. Like, the things that we see are really important. I have one doctor who just opened up a practice a year ago, and she is like, forget about the pan. I need that CT. There is so much stuff I do not see on that pan, including cysts, which we know that 50% of heart attacks are due to an oral infection, whether it be periodontal disease or a cyst that's sitting there that the patient doesn't even really know that infection's brewing in their system. So,
hey, Val Farrow, can you speak to that about how we use we underuse our language, or we soft pedal it or whatever? I know you're out and you've done a lot of consulting. What's your experience? What do you have to say about that? Val? Val.
I'm here. Sorry, Patty. What was your question?
We were just talking about how in dentistry we end up using words that it's like soft pedaling things and not, making it sound not so serious. And the statement that Kandra made was that we devalue what we do by the language that we use.
Absolutely. And that boils back to the patient perception too, right? If we're a little bit of bleeding or just this, or we'll check it next time, instead of really, letting our patients know the medical necessity behind the infection that we see today and why we must move forward with treatment, the urgency. So yeah, I absolutely agree.
Denise, what about you? You've also done consulting. Denise Narsky, can you speak to that a little bit too?
Absolutely.
when we call it transformational vocabulary when you talk in the coaching and consulting world. And what that means is that you need to change your verbiage. Instead of saying just a cleaning, you have to say what it actually is that you're actually doing for that person. You know, maybe you're doing an oral evaluation, or you know, it's something that it's medically necessary for that patient to be seen. You need to change the vocabulary. And just like I believe it was Val, it was just speaking, like she just said, if you say, oh, it's just a little bit of bleeding. Well, you know what, guys, bleeding is bleeding. If it's bleeding, there's a problem. You shouldn't have a problem, you know, if you're like that. So we call it transformational vocabulary. And changing insurance, I would call it a coupon, but that's just me in my book. So switching it up is always a good thing. Getting rid of those words, because when you start to do that, then the patients don't want to come in to see you any longer because they feel that they don't need to do that. I was in Chicago not too long ago, and I was at one of my friends' houses, and her little granddaughter was there. And now, mind you, she and I have been talking a lot about dentistry and a lot about everything. But what did she do that night? She gives her little granddaughter chocolate milk to go to bed with. And to me, and even though we just had this conversation that having a cavity or an oral lesion or extracting a tooth is like extracting a limb, we've just had this conversation, but yet it didn't sink in. And it was devalued in her mind that also what is just a tooth? A tooth is a tooth. So, and it was very frustrating to see that. And I actually yelled at her. I'm like, take that away from your grandchild.
It's so true. This is Val again. And, you know, I think that even boils back to even getting patients when it comes to, when we think about retention, think about the cancellations and the no-shows that is across the country. If you ask a dental practice, what's one of your pain points right now? And a lot of the hygienists will say, or the doctors will say, you know, we're getting no-shows or last-minute cancellations. So how, you know, if we do a better job on the upfront, educating our patients and letting them know that this is a medical necessity and the urgency with these words as, I'm sorry, I can't remember what you said, what you guys call it, but I love that.
Transformational vocabulary.
Yeah, the verbiage that we use with our patients and helping display, you know, the importance and how it is connected to the rest of the body. But giving them a reason to return, I think, is also important. So not only like this is the procedure we're going to do for you today, when we're checking them off and sending them up to our front desk, you know, an admin team, really reinforcing, using that terminology to reinforce, okay, great, here's what we did today. And we look forward to seeing you back in 3 months to do this. Not just see you for your recall or see you for your next cleaning. You know, really putting the value in that verbiage, even when we're handing them off and reinstilling the importance of their next appointment.
I think Val, you just touched on something. Sorry, it's Denise again. I think, Val, you touched on something that's extremely important, that what you just said is that everyone on the team needs to use the same valuing information that a hygienist is using. So if you're going to an assistant or you're at the front desk or you're talking with a doctor, everyone needs to be valuing what you're doing, giving the proper diagnosis, and actually having that patient understand that when you come to see me, this is medically necessary. You are diabetic, and because you're diabetic, your blood sugars are off. Your blood sugars are off today, and your bleeding points and your infection and your inflammation and whatever words you want to use are up. We need to see you. May I get that commitment with you that you understand this and that you will be back to see me in 3 months or whatever time frame you say. But the whole team needs to be on that same page. They just can't drop the ball with us and expect everyone to jump on the bandwagon.
Part of the reason a lot of other team members are not on that same bandwagon is because they don't have the education. When I do a hygiene meeting, every doctor's like, we'll just have the hygienist there. And it's like, no, you won't. You will have your admin team here because they're the ones that have to field the questions up front, and they need to understand this stuff. They need to understand the value that these hygienists are bringing to these patients. And I won't do a meeting if the entire team's not there, because typically I get more comments out of the admin team because they're just blown away by, oh my gosh, I had no idea. It's a whole different conversation now, you know, when they can bring that all together for the patients as they're coming up to the front and asking the questions. So I love that. And I think that's, to me, the number one reason why there's no shows. I get it. People get sick or cancellations. However, I think the biggest thing is the patient's not valuing what we have to give them. But when we can start connecting the dots like that and bringing their health into how it's affecting their mouth or how their mouth is affecting their health, they get it because they get that medical stuff. They don't always get the dental stuff because we've devalued it for so many years.
This is Eileen. Whatever you just said, Denise, right on. But I think the biggest thing, the paradigm is people think that if it doesn't hurt, there's not a problem. So
Absolutely.
they only kind of really get to the medical side if something hurts. And all these infections are silent, many of them.
Yep.
The other thing, too, is with the education, this is the first time I've heard this, and they get scared, and they say, you're trying to scare me, as opposed to, wow, you're really smart. Thanks for telling me that. So it's a work in progress for sure to educate them, and it takes a lot of time.
Yeah, absolutely. Absolutely. And, you know, when I look at what we're being reimbursed in dental for an exam, a lot of doctors are getting $25 to $30 per exam. I just think that's insane because a lot of my doctors are getting like $150 paid by medical. Do you think that they can slow down and educate their patients a little more when they have that, when they realize, gosh, we're getting paid $150 versus $25? I mean, not that it should be all about the money, but that's what we should be being reimbursed for the education that we give our patients. There's very few practitioners that spend a whole hour with a patient in medicine.
We've commodified dentistry, that it's a commodity. It's a crown, it's a filling, it's a prophylaxis, it's a it's periotherapy. Those are commodities. But the expertise is the diagnosis and the medical necessity, the reason we're doing that. That's the emphasis that we're trying to make here. And that's the language emphasis that, like as you're saying so well, everyone, is it just can't be one person. It has to be the entire office that's saying it. So, right. Kandra, let's move on to the next
Absolutely.
one.
So the other question I get often, a lot, I should say, is deductible. Well, you know, their deductible is $10,000. It is, but that deductible is only, it's going to depend on the quality of the patient. If a code is payable and billable, it's going to depend on the quality of the policy and how those particular codes that we submit, if they even apply to deductible. Because I'll show you some EOBs that nothing was applied to deductible. It just depends on the procedure codes, what's being billed out, and how in that person's policy, how it applies. So don't get caught on, well, my deductible is really high, so this will never get covered, because that's not the case. Not the case at all. Go ahead, Patty.
Kandra, you used the term quality of the patient. I didn't understand that one.
Quality of the patient's policy. It's
got it. Okay.
How things are paid are going to be based on the patient's quality of their insurance policy.
Okay.
So just like that's a lot, you know, that's very different than dental too, because most doctors are in network with dental and they get this, you know, X amount for each procedure that they bill out. Most of it doesn't go towards deductible. It's just is what it is. In medicine, it's very different as well. So here's some information I tried to put together, because think about this. When we look at, this was a full mouth reconstruction. We had some infection, we had some cyst removals, we did an eval, pan, CT, and here's the other thing. In medicine, typically they do a 2D radiograph before they then send you in for a CT or MRI. They do. And you can get paid for both of those. We don't have the stipulations in medical that we do in dental. A lot of my offices will do an FMX and a pan because they want an FMX for, specific diagnostics, and they want a pan to look more for, cancer and things that way. We know that they're very different radiographs, but in dental, They only pay for one or the other every 3 to 5 years. Well, guess what? We can bill that PAN to medical and get paid for it. So, so this is just a full mouth reconstruction and what I've been paid in comparing dental to medical. And you can see there's a huge difference in the allowances. Again, even just looking at exams, oh my gosh, what doctors are getting paid for exams in dental versus medical. There's a huge difference in all of these codes and the allowances that are allowed and paid on in medical. So is it worthwhile to bill to medical? It is, because isn't that going to increase our case acceptance? Because now we're giving patients the means to be able to pay for something that they would maybe have to take out, you know, a huge care credit loan, or, I mean, some of these surgeries, they're as much as a car or more. So this is, it just gives you some breakdown of what's being paid out in medical versus dental. Go ahead, Patty.
And this is Lindsay speaking. Just in reference to general dentistry offices versus specialists such as oral surgeons, endo, periodontists, do you see them submitting more to medical, less than general dentists, or just in general, as a dental profession, we need to be more, you know, I guess I feel like I've talked to many patients who go see periodontists every few months, and they tell me, oh, well, they accept my medical insurance, or whatever terminology they use. You guys should do that too, or something like that. So I didn't know if you see more reimbursement and submissions from other specialists versus general dentists.
I can tell you just overall, most dentists in the US are not submitting to medical. I would say it's less than 5% if I polled people. Okay. I mean, that we're truly submitting to medical and having success with it.
Okay, just curious.
You know, no, that's a great question. But to me, a specialist should absolutely be submitting to medical. What I think part of the gap is there is when we're starting to get more dentists in network with medical insurance, because it's just easier. We don't have to always ask for in-network benefits. We don't always have to submit. It's just, there's just a lot of submission that's harder when we're out of network, and we'll do it. But I just think for some specialists, it makes more sense to be in network. But as soon as I say that to a doctor, they're thinking in network as what they're being reimbursed right now with dental, and there is no comparison. There's no comparison at all. We're definitely not apples to apples when it comes to fee schedules with medical versus dental. So,
Kandra, if I can ask a question kind of related to that, is in dental coding, there are not different codes for specialist versus generalist. Is that also the same in medical? The codes are not different depending on your specialty.
No.
Correct?
Yeah, the codes are not different. No. Mm-mm.
Right. So coding is coding from that part. The fee schedule may be different, but a fee schedule is something somebody chooses. You know, isn't it? Yeah. I mean, that's where. This is where and one of the things I see is different, as I know that AMOS, the Oral Surgeon Association, as well as AAP, as well as some of the other dental specialties, they have programs for teaching medical coding, whereas in general dentistry, it's not done. There is not necessarily programs at all.
Right. Yeah, no, they're completely the same codes, no different than in dental. I mean, an oral surgeon would have use the same CDT codes that we do. Yep. So it just depends on the procedures being provided, just like anything.
Kandra, this is Vicki Fedor. I have a question for you regarding credentialing for the medical coverage for the doctors. How difficult is that compared to getting a dentist to be credentialed with an insurance company?
It's been really interesting. In some states, they just won't allow a dentist in. I just had a conversation with TRICARE, and they will not allow a dentist in network with them. They will allow an oral surgeon or a maxillofacial surgeon. And I'm like, you know, as I'm talking to this lady on the other end who really doesn't understand any of this, she has no clue really what dentists do. And I'm like, do you understand that many general dentists do a lot of the same procedures as an oral surgeon or a maxillofacial surgeon? They place implants, they place grafts. All of this stuff is being done in general practices now. And she's like, well, you know, but we just don't do that. And I really started digging into that. And it's, you know, most oral surgeons, they don't have any other credentials behind them any more than a DDS or DMD. So what makes them so different? You know, it just really boggled my brain. And I realized at that moment too, there's such a disconnect with the other people on the other end of the phone at the medical insurance companies, because they really just don't know. They just don't know what dentists really do.
And then when you ask, or you're going to do this for the patient, how do you, you're gonna have to have your administrative staff understand that, and the patient has to be aware that they're may not have coverage.
Absolutely. I mean, with general things like this, there's an exam. An orthopanogram is the real terminology in medicine for a panorex. We have CT and we have CT interpretation. Now you can see the charges there are quite different than in dental. And you can also see that everything was paid at 100% except for $62 of it. So that looks totally different than what most times we are coming out of a dental chair. What we basically tell the patient is we're going to submit to medical, and they're going to reimburse us whatever they're going to reimburse. Some of these things we can also then submit to dental. So now, guys, we get to double dip. I call it double dipping. I have a really great Seinfeld clip that goes along with the double dip. But we're the only specialty that actually has two different insurance companies that, or not insurance companies, but insurances that we can tap into to get up to our full fee that we have charged out. So often we start to get overpayments because medical will pay more than dental, or sometimes we don't even have to go to dental. But there's strategies around some of those things when we first start implementing in the practice. Here's another CT. We just got this last week. A doctor I'm working with, her very first medical claim, and this is what came back. She had a CT scan, and it was also interpreted. We can also charge for interpretation, and it was paid at 100%. You can see the diagnosis codes on the bottom. The first one was an abnormal radiographic finding. So she had done a pan, she saw something that was abnormal that led to a CT. And then from the CT, we were able to finally, further diagnose what was going on with this patient. So that's what that looks like. Once we have those diagnosis codes in, we can attach them to the actual procedure, and that's how we get paid. In dental, we wouldn't have any of these diagnosis codes. We would just submit these procedures. That's it. But in medicine, you need to have those diagnosis codes. Here's also another claim. This was a very large case. This just happened to be a lower reconstruction surgery, and it was paid at $33,300, no deductible, no co-insurance. Now, this patient also had surgery at the beginning of the year in January. I think it was January 4th to be exact. And same thing, nothing was applied to deductible or co-pays. It was paid at almost 100%. Actually, it was paid at 100%. I think the only thing that wasn't paid at 100% was when we did a post-op reeval 91 days after the surgery, and I think they applied $150 to the deductible. So when we look at deductible, we can't get caught up on deductible. But what I always tell patients, because I do some billing for some of my doctors as well, so that I keep relevant with it, we will do this as a courtesy for you. This is what the cost of the treatment is. If in 30 days we don't have payment by insurance company, then we need to tap into your care credit or whatever it is. However, whatever we've done for financial arrangements, whatever the practice has done with financial arrangements. I don't get into the financial arrangements. I let them do that.
I have a question.
Uh-huh.
This is Ellen Anderson. I work in public health. Does this also include Medicaid and Medicare?
You have to be a provider for Medicaid and Medicare. A lot of practices are not, and that's their choice. Either they opted in or they opted out. And even with sleep appliances, a doctor would have to be a DME supplier for Medicare to be able to submit to Medicare.
Okay, I work for a federally qualified healthcare center, so I'm assuming that is that our dentists are Medicare providers or Medicaid providers.
Uh-huh.
So
yeah, you absolutely could submit those exams and pan CTs. I'd have to look at your procedures by provider report and see what's there, but there's lots of opportunity to submit to medical. I mean, the beauty of that is why not save some of their dental benefits for dental things, especially when you know that their reimbursements are, their max is so limited, where they don't, it doesn't take much, and there's always that struggle between hygiene and doctor, like who's going to get the $1,500 max that they got this year, the doctor for a new crown or hygiene for a periodontal therapy, I mean, it can't possibly treat our patients. I remember we used to do the 5-year plan to get them back to health, or get everything restored in their mouth. I mean, it's just insane. Let's leave all that infection in there for 5 years. Now that we know what we know, it doesn't make any sense.
Right. Okay.
If we can utilize medical insurance, it's a win-win.
Kandra, this is also, I think I connected you and Ellen, and this goes back to our mastermind from last month with Perio Protect. With your special needs population, there are many of the residents that could probably benefit by having Perio Protect trays, and we were going to look at those under durable medical equipment or something else under the Medicaid and Medicare system. And that's kind of, Ellen, that's where you were talking about with this, right?
Well, pretty much everything, because I also work with typically functioning individuals as well, and they're choosing not to have dental work done because it may not be covered under their dental plan, and it's whatever state plan that they have picked out. So whether it be periodontal or endo or surgical.
Yeah, it's and it is hard. It's hard for us to see patients sitting there having to wait for treatment, and unfortunately a lot of it is silent, and people just can't afford it, so they just don't do it. I have a friend that actually is she's a nurse for a transplant company, and she's like, you cannot imagine how many patients die because they have an infection in their mouth. They come into the ER, and let me tell you, that ER doctor is going to submit that exam and all the radiographs and anything else that they do in that ER to medical and get paid. So we can too. We can get paid for those things, and they send them a referral to a dentist. The patient never goes because they don't know how they're going to pay for it. And the patient comes back and they die in the ER a week later. She's like, it happens all the time. I mean, young people, 30s, 40s, 50s. So we have to think more globally. What else could this be? How else could this be affecting the patient? There's so much medical necessity in a dental practice. It's pretty overwhelming. And usually when I do my meetings with teams, we have a 4-hour startup meeting. They come out and they've pinpointed every single patient has some form of medical need, medical necessity. I mean, and we can't, obviously the office isn't ready to take on that level of claims yet. So we have to scale them back a little bit until we're ready to be able to, submit that many claims out the door. But it's awesome to see that aha moment where they're wanting to start doing blood draws and everything else that they can in their practice. So pretty cool. So why would we limit ourselves to just dental insurance? It just doesn't make any sense with where we're at. We've allowed dental insurance to dictate everything about our practice, and it's devalued everything that we do and that we provide, in my opinion. So it's time that we close the divide. and this is what I love about this group, because I know you guys are forward thinkers. And the more that we can continue to do this, you know, reach out to me if you guys need help with this. This is what I do. It's easy to talk about this, but we actually need to do it and successfully do medical billing. That's the ticket, because you're going to hear from a lot of people that it doesn't work, and it absolutely does. But it's like anything. You have to invest the time, and you just got to dig in and make it happen. But a lot of that comes with shifting our mindset and realizing that dental is a medical specialty, and we absolutely have a huge value to our patients. And how can we give them another alternative for payment for services that we provide?
So are there any final questions, comments, anything you want to ask Kandra at this point? You probably want to get a shot of this. If you miss her information, she's pretty easy to find out there. You can always reach through me. As Kandra is all about all of us learning and helping. And this is, again, as she said so much, this is the core group. We're making a difference. That's what dental codology is all about. That's what the insiders are all about. Any final comments, questions, anybody?
I have a question.
This is Sandy Rago.
Oh.
I
Hi,
have
Sandy.
a question. Hi. If a dentist wants to bill for medical for, say, a sleep apnea mouth device, and he's out of network, does that then just automatically go as an out-of-network charge against the medical insurance?
It can. I typically ask for what we call a gap exception, which is what we're asking to be paid for that procedure this one time as an in-network provider.
Oh, wow.
Yeah, and that's very,
okay.
It's doable. There are some insurance companies that aren't even allowing that. I mean, they're just being real pain in the rear. You know, HMOs are obviously the hardest because they're out of network. And the great thing with sleep appliances is dentists are the only ones that can provide them. So if they don't have a dentist within a 30-mile radius, 30, I've heard up to 65 miles, which is insane to me to ask somebody to drive that far. But, you know, they absolutely will allow a gap exception. Or we get the patient on the line and the patient asks for it and says, I don't want to see anybody else. I mean, personally, if I was going to be seeing a surgeon for something, I'm going to pick that surgeon, not my insurance company, based on their skill, not just some Joe Schmo that signed up for the insurance, you know, to be an in-network provider. And that they typically will grant that.
Wow. Okay, great. Thank you.
Mm-hmm.
Kendra, this is Vicki again. When you have all these, this is such a big hot topic right now in dentistry, and there seems to be a lot of certifications out there for medical billing for dental purposes. Is there something that you would recommend for any hygienist that wants to go into this field, any specific certification that's worth their investment?
Not really, because when you go to certification, they're gonna have you learn all parts of the body that don't apply to us. So I mean, I've just dug in and I've learned, and I have a great mentor that who's helped me through the whole process, and keeps me on track when I have stupid questions, which are stupid for now. You know, they obviously there's so many things to consider when we're billing the medical, but you know, every once in a while I have a flashback to my dental days and I ask a question that I should know better, but it's like I have to have a reality check because these questions come up all the time that I start to doubt myself even. But it's pretty straightforward with medical. But
And Vicki, you set me up beautifully, because the process that dental codology is working to create in the longer term point of view is in medical coding. You can take medical coding courses through a lot of different venues. But if you want to become certified or get a credential in medical coding, you're going to go through an organization such as AHIMA, American Health Information Management Association, and there's other credentialing bodies. And as it's evolved, you can become a certified medical coder, but you can also have a specialty in gastroenterology or in cardiology. What I want to see and what we're working toward is building one that is in oral health. oral medical coder specific.
Because
So
even,
that's,
Patty, even when I look at resources that are out there, there is nothing. They don't even think they have ENT listed. I mean, there's nothing that's specific for what we do, and there's so few codes that we actually use that I mean, I asked my medical billing company that can do the credentialing and everything for dental practices. They actually were medical billers before they started entering the dental space, so they know this stuff. They know the medical billing side. There's a lot of companies that, you know, were in dental and learning how to go to medical. It's much different and it's harder to grasp the concept. I asked them about all of their billers that they employ, and they said none of them have any certification at all. We've trained them.
something else to consider, there are numbers of courses, and Kandra can link you up to some courses that she knows and some people that she might recommend. Going to a 2-day course is not going to get you everything you need to know any more than going to a 2-day implant course or 2-day any course, especially in the CE venue. It's going to get everything you need to learn. This is a process. This is a big process, and what we're trying to introduce here is the idea of starting to think medical necessity, think medical documentation. That's what you're doing, and that's what we need to shift our thinking to. So again, thank you, Kandra. You did an awesome job. I know everybody here appreciates it, as will the people that listen to this this program later. I know I appreciate every single one of you here. You know how to find me: text, email, Facebook, Instant Messenger. The dates that you want to have on your calendar is 8/25 is our next dental chirology consortium meeting, and 9/11, Wednesday 9/11, is when Sandra is going to talk to us about cannabis. If you have questions about those dates, go on Codology, look at the events. All those events are already listed through the rest of this year if you want to get them on your calendar. Until the next time we meet, dental codology is about charting our future. We're not waiting for anybody else to create our future for us. We're creating it for ourselves. And I know we're up to it. So thank you, everybody, and good night.
Good night. And thank you.
Good night.
Good night, guys.
Very good. It was very good. Thank you.
Feel free to reach out if you've got any questions. That's what I'm here for.
Oh, Kandra, I'm going to be talking to you soon.
All right.
Thank you. Bye-bye.
You're welcome. Bye-bye.
Bye.